Thank you everyone for this very interesting forum. So the topic Chitra has given me about immune-mediated inflammations due to COVID and vaccinations. So let's look at what does COVID do. In a nutshell, you do need ACE2 and you need TMP, RSS2, receptors for the virus to adhere and then get entry into the cell and cause whatever it does. Now, both the receptors, after multiple reports of them present, absent, but eventually it has been beautifully shown that these receptors are expressed in neuroretinal cells, mainly ganglion cells, inner plexiform, inner nuclear, and photoreceptor outer segments. We also know that RPE has toll-like receptors, and it could be the one which again might get involved by the COVID virus. So COVID produces three kinds of changes all over the body, though we are understanding more and more. Basically vascular, inflammatory, and neuronal. And over a period of time, as we understand, is the inflammation is the key, and the other two changes may be a part of inflammatory cascade that it is inducing. When we talk of vascular and neuronal changes, we did actually a prospective trial, cross-sectional, where we, went to the COVID ICU where our COVID patients were, and we just screened them, and of course, doing all the whatever the requirements were, we screened these patients. And then we followed them up during the convalescent phase. And for convalescent phase, the hospitalized patient, that is 73, were screened 2 weeks after they were discharged. And for home isolated, we screened them 17 days after COVID testing. Interestingly, we did not find any retinal lesions or inflammations which could be attributed to COVID-19 during the acute phase. No retinitis, no necrosis, no inflammation. 5 patients, which was 5% of the total, during the convalescent phase had cotton wool spots, which may or may not be associated with retinal hemorrhages. And they had no other retinal finding, no visual symptom. And these spots actually appeared 30 days from the day of the COVID diagnosis. These 5 patients did have associated comorbidities like diabetes, hypertension, anemia, coronary disease, and kidney disease, but none of them had features other than the cotton wool spot, which were suggestive of any disease. Now look at this patient. These are the cotton wool spots which were actually seen. These spots were seen much later, 30 days or so, and they appear like this. And this is in the inner retina, which is one of the layers predicted to be involved. When we published it, we called it COVID microangiopathy like HIV. And of course, on OCT, these findings that show there is vascular events. You can see the area of non-perfusion, and which was not, of course, a one-time event, as I will show you. This is an example of a 73-year-old man. When we scanned him in the ICU, he was doing fine, nothing in the retina. But 44 days after COVID-19 diagnosis, the cotton wool start appears in the left eye and the right eye is normal. 2 weeks later, we see 2 new cotton wool spots appearing in the right eye, which was normal, and the left eye is kind of resolving cotton wool spot. So is COVID inducing an ongoing insult? This is something, we would love to find out. And does it predict anything in the brain? What exactly these cotton wool spots represent, we don't know. We thought of thrombotic microangiopathy, but seems unlikely. Most plausible seems to me is the immune mediated, because these are fresh lesions and cytotoxic T lymphocyte is probably infiltrating the ganglion cell and plexiform layer. These are definitely not direct viral infection, and enhanced damage by the virus in the retinal microvasculature in presence of systemic comorbidities was something which we considered. So we wanted to a longitudinal follow-up on these patients, which we did. And over the longitudinal follow-up, we did find that these would resolve over a period of 12 weeks on an average, leaving just few changes in the retinal nerve fiber layer. So we could not find any systemic correlate. It was self-limiting. We even did MRI in a couple of patients because many studies were suggesting that if you see these cotton wool spots, probably it means there is some neuronal damage in the brain. Like we could not find anything. So what we reported was that they disappear, and to corroborate our results, there is recently a study in VGO as well, where in Singapore, they recruited patients. They did the OCT angio for the patients who had COVID and those who did not have COVID. And they found that the microvascular signs are related exclusively to COVID. So it's safe to call it COVID microangiopathy. Vein occlusions, we all know the only implication is this is the venous occlusion that happened in a 28-year-old within 8 hours of receiving Covishield vaccine. No risk factor, but I think the only marker is if you catch it early and it's not fully developed, probably there is a role of steroids. So I don't have honestly the biomarkers to suggest which are elevated, but going by what is available in the rest of the body, high dose steroids may help during the very early stage. However, if you see patient when it's already formed, of course, anti-VEGF. AMN, that is macular neuroretinopathy, and paracentral acute middle maculopathy, these kind of lesions, they actually just represent ischemic insult. They have been reported, and I would like to show you this patient who's a 50-year-old man, and he was in our ICU for COVID pneumonitis, and visual loss happened on 5th day. But we saw him after 2 weeks after he was discharged. So there was hemorrhage in the left eye, and there were these kind of white lesions which have been reported in this case report as punctate kind of the lesions, as you see here. Now, what do these lesions represent? We did the fluorescein, and you can see these lesions are actually punctate hyperfluorescent. And on OCT, what we found was these lesions, which is due to ischemia. But interestingly, when we did the OCT through the lesions that were punctate, there is a loss of ellipsoid zone, and you can also make out there was inflammation in the eye. So it's a kind of photoreceptoritis that it is producing, and I would rely on my imaging biomarker to see this kind of inflammation, and I would treat it with my anti-inflammatory agents. In the same patient, we also found the new vascularization, which is very different from the new vascularization we see. It's more of a non-sprouting into susception new vascularization that has been reported in 2 animal models back in 2012, and mostly in viral inflammations in rats. So I'm going to scan more of my patients for this. COVID as well as vaccination both are inducing either the new inflammations in the choroid RPE complex, or there is reactivation of the old one. Now here I could find that like we have a series of patients, and I collected the vitreous, and it was the TNF which was elevated. So if I don't find a cause and I'm treating, I know anti-TNF is the one which is going to work, which has now become my first line of therapy for COVID-induced, whatever it is, choroiditis. This is within 24 hours of the injection, you can already see the lesion starting responding to therapy. Many of our patients who were, quiet for almost 2 years and developed the vaccine, they have started developing these new lesions following vaccine. So I think this vaccination is kind of, triggering some kind of autoimmune response somewhere, and these lesions are coming back. And very interestingly, don't be in a hurry, though off the comment, but teleconsult was a major culprit besides the vaccination in inducing the reactivation, because on teleconsult, people will in a hurry to stop biologics or immunosuppression, which actually we reported in BGO that resulted in very high number of patients who came back to us with relapses. Just to show you the last case and how the phenotype keeps on changing even in the same patient. So when we talk of personalized medicine, it is not about, I know it's about genotype, phenotype, but even in the same patient, the phenotype could change from time to time, and you may have to customize your therapy based upon the changing or evolving phenotype. Now, this patient I had seen in 2018, and he had a small PED which was there, and we did not do anything. The fluorescein was done, so everything was normal. Then he develops COVID. And 1 month after COVID, he was on oral steroids because of deteriorating vision. And he just came to us with a second opinion of query retinitis. So I'm sorry, this is kind of not animated. If I can, I'll just remove it. So this is what it was. You can see there was this retinitis, which was on OCT. You can see it was kind of full thickness retinitis. There was definitely vascular involvement, vasculitis, and there was some retinal hemorrhages as well. The left eye, he had undergone atrophy of the retina, and you could see there was total atrophy of the retina, and which was very well appreciated on autofluorescence. So I thought it was probably COVID retinitis, because to me it looked like SSPE or other RNA viral infections that I see. So in my mind, it was COVID retinitis. So I took a tab, did RT-PCR. COVID was negative. So I honestly did not know what to do. And during the workup, his blood culture showed staph hominis. Now that comes a problem, because was it endophthalmitis? Anyways, we treated him for endophthalmitis because we couldn't do anything for COVID. So during 3 weeks, the lesion starts responding, but in the left eye, there is a lesion. Again, we pushed in more antibiotics, and after few weeks, this is what we end up with. If you ask me today, when I'm looking back at this, it was not infective endophthalmitis, and probably antibiotic didn't do anything. Probably the viral retinitis resolved on its own, but I would have loved to have biomarkers at that point of time as to, what it could be. Did fine, lesions resolved, we were kind of okay with it. Till 8 months later, he comes back with the recurrence of inflammation in the right eye and also in the left eye. Now, what he has is diffuse vasculitis, which was not there before, which is something, it looks like autoimmune to me, and same is in the left eye. So again, we did everything negative, and we started him on oral steroids and azathioprine, to which he was kind of responding. But the day, that is a month later, when the steroids were reduced, he comes up with synovial thickening in the joint, in the right hip joint, which is suggestive of inflammatory arthritis. Now, whether this vasculitis is a part of multi-organ inflammation secondary to COVID or not, I think it is. So he was again changed to methotrexate, and now we have to see the response. So to conclude, COVID-induced inflammations are evolving. It's very important to characterize the clinical because we don't even understand the phenotype in COVID, the big challenge, the imaging and biological markers so that, we can actually evolve some kind of targeted therapy in these patients. Thank you once again, Chetra, for your kind advice.